All right, so welcome everybody. My name is Mike Reed. I'm one of the pharmacists here who, if you don't know me, I've been here 20 plus years. I do chemo, BMT, inpatient, and outpatient. Today's objectives are going to be to go over the toxicity, side effects, and pharmacology, and some pearls for some what we consider classic cytotoxic chemotherapy meds. It's a larger group this time, but anybody who has questions and wants to join in, feel free to do that. You can jump right in. If you have any interesting stories or teaching points from patients that you've experienced or treated, please feel free to join that. There's lots of slides here, 160. The ones highlighted in blue, we're definitely not going to go over. Those are really just background information for you. All right, so let's get going. To just start off in the beginning, just to get thinking, so why is chemotherapy unique among medications that is most often dosed in body surface area, milligrams per meter squared? If you think about it, there's probably no other medications or classes of types of medications that really are dosed this way. So when we're going through the presentation, just keep that in the back of your mind, and we'll kind of talk about that at the very end. All right, this is just to remind people of the cell cycle site of action. Drugs that are non-cell cycle specific, such as anthracyclines, work in all phases of the cell cycle, so these work on preformed DNA. Other meds, such as the Taxanes and the Vinca Alkaloids, work in mitosis. And just as a reminder, G1 is where protein synthesis and organelles are duplicated. S phase is obviously DNA synthesis, and G2 is microtubules and structures necessary for mitosis. So different drugs work on different phases, and even within certain drugs, they work on not equally in all different phases. All right, so since we're talking about cytotoxic chemotherapy, I just wanted to go over some quick background. Gone% growth is exponential growth followed by slow growth versus plateau. So this is the way tumors grow. So it's kind of like an S curve. So it's really fast and it flattens out, or it slows down and it plateaus. Resistance is independent of the chemotherapy agent used and depends on the number of cell divisions after treatment. So really that means the larger the tumor size and the longer the delay in initiating chemotherapy, the more resistance you're going to have, which seems to make sense. The fraction of tumor cells killed by each chemotherapy administration remains constant. So if you give a cycle of chemotherapy, you get 90% kill rate with cycle 1, then the remaining tumor cells you get 90% for that one, and so on. And then the last one is the rate of cancer cell death due to treatment is directly proportional to tumor growth rate at the time of treatment. This really means that likely cells that are tumors that are growing quickly are going to respond better to cytotoxic chemotherapy. So we have 4 classes of drugs we're going to talk about here, and they were developed in the 60s, 70s, 90s, and 2000s. So a lot of these drugs have been in use before you were actually born. So we'll jump right in. Anthracyclines are natural products isolated from microbial sources. These are deeply colored agents were originally used as dyes, and daunorubicin, for example, has a nickname of Red Death because it was a toxic drug, but it's this bright red compound. And mitoxantrone, which I'll show you a picture of that later, is actually really bright blue, and that can change dye patient's urine, make it blue, make it green. These are one of the most commonly used anti-cancer agents, and they have a broad spectrum of activity that's actually similar to alkylating agents and taxanes. So this is just a list of the drugs, and I just want to point out that there's 3 liposomal versions. Doxo and Dono have a liposomal version, and we have a combination of daunorubicin and cytarabine, which we'll talk about, known as Vyxeos. Mitoxantrone is generally included in this class, although technically it's not an anthracycline. All right, so we're not going to do a lot of structures, but I did just want to point this out. If you look at doxorubicin and daunorubicin, they really only have this slight difference in chemical structure. Single hydroxyl group is C14, but they do have distinct patterns of activity. Daunorubicin and idarubicin are primarily for acute leukemias, and doxorubicin and epirubicin have this broader activity, including solid tumors. And mitoxantrone, if we look at the bottom right, is often included in here because it has similar uses and similar functions. So multiple mechanisms of action. I'm not sure. Let me see if I can get rid of this. No, I didn't want to do that. Sorry about that. Okay, so back to, they actually have multiple mechanisms of action. Okay. They induce formations of topo 2 isomerase DNA complexes. This is the main mechanism of action. They also have intercalation between base pairs that inhibits nucleotide replication, and they have this enzymatic reduction, which produces these highly reactive free radicals. And this not only adds to toxicity or efficacy, but also adds to the toxicity. And just a note that mitoxantrone actually has a decreased affinity to form these free radicals. So this is just a schematic, and if we look at, if you think of the molecules that had those heteroplanic rings, they get inserted perpendicular to the sugar ribose backbone of DNA, and those would be where we have the red arrows. And what this does is it increases this torsional strain, and it kind of changes the structure of this background. And these DNA-associated enzymes, proteins, and polymerases and transcription factors are less effective at binding when these drugs are intercalated in there. This is the main mechanism of action. This is topoisomerase 2. And you can always think the 2 makes the double-stranded breaks. It's a transient break, and it's necessary for the unwinding and the transcription. And anthracyclines really are these topo 2 poisons, and they form this stable drug DNA topoisomerase 2 complex. And they are one of the most efficient inducers of apoptosis. And maximum killing really occurs in the S and G2 phase. So resistance occurs through multiple different mechanisms. We have the MDR gene product, which is multiple drug resistant. We also have a very similar, genetically different, but phenotypically similar MRP pump. You can have downregulation of topo 2. You can have increased neutralization of these enzymes, increased mutations of p53, and overexpression of anti-apoptotic molecules. Mitoxantrone is different because it's not actively transported by this MRP pump. And this is just a schematic that I pulled from Google Images a few years ago. The pills here, or capsules, are really the lipid bilayer of the cell. And this just illustrates that there's a pump here. And the multi-drug resistance really means that you get exposed to one drug, for example, Etoposide, the tumor cells produce multiple copies, increase this cell, and then you can get exposed to other chemotherapy, such as anthracycline, and they can also be pumped out by this cell. So these are just the indications for doxorubicin. This is the prototypical drug of the class. We're going to talk about that one. I'm not going to go through all the indications. I just want to point out that it's been around for a long time, and there's lots of FDA-approved indications, and there's also multiple non-FDA approved uses. So we have a 35-year-old male with stage 4 Hodgkin's disease. He's receiving ABVD, which is doxorubicin, bleomycin, vinblastine, and dacarbazine on days 1 and 15. He's also getting concurrent radiation to a large mediastinal mass. He comes to, it wouldn't be the onc, it would be the heme clinic for his 5th cycle of ABVD. And he complains of tachycardia, shortness of breath, non-productive cough. Physical exam reveals neck, vein distension, pulmonary rales, and ankle edema. And he's currently on amlodipine for hypertension. So when you think of anthracyclines, one of the most common toxicities or side effects is cardiac toxicity. And it's really divided into 3 sections. You have acute or subacute, which can occur immediately after treatment. You have chronic cardiotoxicity, and this is really, I think, the major concern, and this results in a cardiomyopathy. This is really the most common and clinically most important. And you get late onset, which results in intraventricular dysfunction and arrhythmias, and this can actually occur years to decades after treatment. So we're just going to go over those quickly. So the acute and subacute cardiac toxicity occurs like immediately after a single dose. This can actually occur while you're infusing a drug. You can get electrophysiological abnormalities. The most common one is sinus tachycardia, but you can also get QT prolongation and other type of arrhythmia. We don't put people on telemetry for this. These effects are seldom serious, but there are rare cases that they have resulted in acute failure of the left ventricle, and actually there are case reports of fatal pericarditis, myocarditis syndrome have been reported. So the mechanism of cardiotoxicity, this is really the congestive heart failure type 1. There's really type 1, which is death through necrosis, and obviously it's not reversible. And there's really cardiomyocyte dysfunction, which can be reversible. And arbitrarily, it occurs within a year of treatment. It can happen earlier, it can happen later. And the exact mechanism is unknown, but it's not probably, it definitely is multifactorial, and it's related to free radical formation and topo 2 beta damage to the myocardium. And this is kind of interesting, and we'll talk a little bit about that on the next slide, because these are all drugs you often don't see a lot of changes or new discoveries with these. It's related to peak concentration, and I have a graph here. So this is from 1996. On the left axis, there's the probability of CHF, and in the bottom, there's the total dose in milligrams per meter squared. And this is doxorubicin-induced congestive heart failure. There was about 4,000 patients here and 88 cases of congestive heart failure. And this was really for a bolus, a short infusion, which is important to keep in mind that the cardiac toxicity is related to the concentration, so that is really related to the infusion time. So shorter infusions, higher concentrations, more toxicity. And if you really look at this, it's around 400 where you see 400, 450, where you see the significant increase in the probability of CHF. All the anthracyclines can cause this, and they have different potency, I should say. So if you have doxorubicin is 1, daunorubicin and epirubicin are half as toxic per milligram, meaning you can tolerate approximately twice the amount. Idarubicin and mitoxantrone are about twice as toxic, so meaning you can probably tolerate about half the amount. And there's multiple different conversions out there. And this is one thing that we do when patients switch. For example, they had breast cancer and they received AC. Now they have therapy-induced AML. We go back and calculate how much anthracycline exposure they've already had. And I just pulled this up. This is just a screenshot from Epic. If you ever want to, or HealthLink, if you ever want to look at this, you can just type in lifetime dose tracking, and any medication that was, any tracked medication that was administered here in the UW Health system will be calculated here. And it'll give your percentage that the patient received. For example, this patient had 110% of the maximum dose we had in the system. And the maximum doses, they're not hard stops, but they're used to calculate this. And they're also used to trigger the warnings the nurses get when they're going to administer the medications. And it would basically say that the dose you're administering is going to push your patient over this threshold. All right. So risk factors for the toxicity include previous cardiac irradiation, elderly people, younger people, female gender, pre-existing heart disease, hypertension, and therapy with other drugs that can cause cardiac toxicity, such as like epothilones, trastuzumab, or paclitaxel. And there's probably a genetic predisposition. There's a wide variety of individual sensitivity. So some people really can show these effects at 300 milligrams per meter squared, and others can tolerate, 1,000 milligrams per meter squared. So sometimes it's difficult to predict. There are guidelines from ASCO on what to do based on your cardiac risk. And I don't know if we've fully implemented those. If any of the fellows out there are interested in a project, I think this would be an interesting project to do and probably beneficial. Just a couple of the key points are, which makes sense, is modify or manage modifiable cardiovascular risk factors, so smoking, hypertension, diabetes, things like that. And then it also has some other strategies, and these are not always possible for your patients. So you can use the cardioprotectant dexamethasone. We'll talk about that. Continuous infusions have less toxicity, but you're generally going to follow what the regimen is. You're not going to take a bolus regimen and infuse it over 24 hours. And liposomal formulations also have less toxicity. And it does talk a little bit about radiation that kind of makes sense, is use the least effective amount of radiation possible. And still looking at or being investigated are meds to treat for secondary prevention, and these would be beta blockers, ACE inhibitors, and angiotensin receptor blockers. So this patient is the male who's coming in. He has symptoms of congestive heart failure. It would be unusual for him to actually have that because he's only got 200 milligrams per meter squared, which is of doxorubicin, which is pretty low. He does have some risk factors, though, concurrent radiation and hypertension. So ejection fraction monitoring guidelines, we won't go through the details of these, but I do want to point out that they are available and that there are actually various guidelines on when you should do an ejection fraction. You definitely should do that prior to initiating the drug. And if the patient doesn't have any risk factors, you might not necessarily have to do it before the first dose, but you should do it, with the first cycle at least. And then really probably check after 250 to 300 milligrams per meter squared, and then probably after each cycle after that would be a rule of thumb. So prevention is key. Limit lifetime doses to around 450 of doxorubicin equivalent. Longer infusions have decreased cardiac toxicity. And we'll talk about the cardioprotective agent, Extravasation, liposomal formulations that oftentimes can't be substituted. In some cases they could. They have less toxicity per milligram. And this is going to necessitate lifelong monitoring for the patient. So cardioprotective medication. So what's not effective? A lot of things were looked at. N-acetylcysteine, coenzyme Q, vitamins B and C. What is effective is dexrazoxane. And I don't know if anyone here has seen that used. I've probably seen it used less than half a dozen times since I've been here in the 20 or so years I've been here. So what is replacement therapy? When would you use this? Well, first of all, I guess we should sort of say is what is it? So it's believed traditionally to exhibit its cardioprotective effects by chelating iron. So it's related to EDTA, it's an iron chelator, and preventing free radicals, which are thought to cause this damage. Recently, and when I say recently, probably within the last 5 to 10 years, there's more evidence that it binds to topoisomerase 2 beta, and that's its mechanism. And we'll talk about that in a second. It's approved for metastatic breast cancer in patients who are responding to doxorubicin. So it's metastatic breast cancer, not early stage, and who have received 300 milligrams per meter squared. ASCO says other malignancies similar to above, you could consider that same situation. There's inefficient data for use with other anthracyclines, but given their mechanism, there's evidence of it. It's been used for epirubicin, so we know and we believe that it can work for that. But this is kind of interesting. This is a different mechanism, or one of the newer mechanisms. And so, like I said, for a long time it was thought the protective effect was due to iron chelating, even though other iron chelators, such as Desperox, didn't actually have this protective effect. So in humans, there's two types of topoisomerase 2. There's an alpha and a beta. Alpha is found predominantly in proliferating cells and required for DNA replication, and this is really the basis of the anthracycline efficacy, tumoricidal activity. Topo 2 is found in quiescent cells, including cardiomyocytes, and this is thought to be the cardiotoxicities. So the anthracycline binds this cause dysregulation of mitochondria, which results in increased reactive oxygen species, which is really where the toxicity is. So dexrazoxane really binds this topo 2 beta and prevents the anthracycline from binding to it and causing this cardioprotective effect. So myelosuppression, why isn't it used? Why don't you see it that often? So myelosuppression is really potentiated. There were concerns about efficacy in some early older trials with early stage breast cancer where they saw faster tumor progression, which is really why it's FDA approved for metastatic. And it's really unknown whether these are effective for long-term cardiac effects. All right. Some other toxicities, bone marrow suppression is primarily neutropenia, which is the dose-limiting toxicity. Nadir 10 to 14 days, recovered 3 to 4 weeks. It's definitely a vesicant, so IM sub-Q are contraindicated. I'll mention extravasation on the next slide. Nausea and vomiting is level 3 medic potential. So when you have your AC regimen. You're going to use an NK1 inhibitor, 5-HT3 inhibitor, and a steroid. Mucositis and diarrhea, as with most medications, that you get greater toxicity, GI toxicity, when you get longer infusions, and alopecia is going to be universal. This is extravasation. We have a really good guideline on UW Health if that ever happens, and I expect that you will get a call, unfortunately, at some point in your career about this. So stop injection, aspirate, and really what the call for you would be is what the treatment would be, what you want to treat with. And I pulled these two slides because if you look at the molecules, there's Xenicarb and dexrazoxane and Toltec, and they're absolutely identical. It's the same drug. And what I find interesting is that Toltec was the first drug that came out, and it actually has an indication for extravasation. And the company put this little blurb out, and I believe this was probably 20 years ago, and it said, well, we have a patent on this drug for the treatment of extravasation. And if you use another drug, so you use like Xenicarb, which was much less expensive at the time, and institutions were doing that you are infringing on our patent. So it's kind of interesting, exact drug, but they have this one patented, and they're telling other people in healthcare institutions not to use the other drug. You have to use ours, even though it's more expensive. All right. So this is a real patient. I just cut this from the patient's chart. Basically, to summarize, it's a patient with breast cancer. She was treated with AC and tamoxifen. Then she had a reoccurrence, and she was treated with radiation and TCH. They did her Herceptin. Then she presents with fatigue and cyclical episode, and she's found to have with a bone marrow biopsy AML. So she has therapy-related AML, which is again one of the side effects that you have with anthracyclines, especially when you're used in combination with other drugs like alkaloid agents, so the AC regimen for breast cancer, for example. So this is from the nurse's note, and really they went to give the chemotherapy, and it says 1 to 2 mils were infused, blood return was established. Upon looking at the patient's chest, about the Hickman site, there was redness along the tunnel site, 1.5 inches, blood return. They went to lift the Band-Aid, and the patient complained of pain. Unsure if the redness had been there before. And keep in mind that the patient had breast reconstructive surgery. So the nurse stopped the chemotherapy and calls the fellow, and literally it was 8:15 on a Friday evening, and you're trying to triage this patient. What should I do? And you're not in-house, you're actually at home at the time. Anybody have any thoughts? Would you use dexrazoxane? Would you observe? Would you continue the chemotherapy? Any ideas? I can tell you what happened, but there's not necessarily a right answer there. So I will tell you that I believe the next day is they did stop it, they did hold it, they did not give dexrazoxane, and I'm not sure, I don't remember to know what the rationale was. It could have been a leaking central line, but what they did is, which really would have been the cause of a central line. So the patient went and got a dye study the next day, and catheter was safe to access, and they restarted it. So believe it or not, you can get these dye studies, fluoroscopy, on the weekends on Saturdays, which I was surprised to find out. This is just a picture of what happens if you get peripheral administration and get an extravasation. And we won't go into a ton of detail because I believe you have a lecture about that. But anyway, there is the antidote or treatment for extravasation. If you administer it, the key points are you need to do that within 6 hours of extravasation. It's a 3-day course of therapy. You need to reduce it for renal function. And it's a 2-hour infusion, and basically you take the ice packs off and infuse it in the opposite extremity 15 minutes after you take the ice packs off. So other side effects that you can get with the anthracyclines, or you can get facial flushing, which is histamine release. You can get a doxorubicin flare, which is a erythematous red streaking proximal to the site of a peripheral infusion. You have to be careful to differentiate this from an extravasation. Hyperpigmentation and elevated skin discoloration, and secondary malignancies. And like I said, they're more common when they're used in combination with an alkylating agent. You can also have radiation recall, which is enhancement of radiation injury to tissues when you infuse the anthracycline. Pharmacokinetics, the only thing that you need to remember is that it has extensive liver metabolism, and it's going to require a dose adjustment for decreased hepatic function. And there's different tables in here. This is the one for doxorubicin. There's different dose recommendations for the different anthracyclines. And this is just for your reference. I think this is a really good one. If anybody's interested in it, is dose adjustments for patients with renal and hepatic function. All right. And we're going to skip this. So this is another quick case. BC 39-year-old HIV-positive male presenting with rapidly growing retroperitoneal mass, extrahepatic biliary obstruction, evidence of tumor lysis with urea neuropathy, plan to receive a first cycle of hyper-CVAD. Drugs are listed there. He has an unclassified B-cell lineage lymphoma, and he comes from an outside institution. Billy 6A, uric acid 10.2, down from 14.9, and his creatinine has improved. It's still elevated at 1.7 from the mid-2s at the previous institution. So, knowing that we talked about these drugs, anybody have any idea of what we're going to do? Is there an appropriate regimen to treat with hyper-CVAD? Do we do full dose? Do we hold anything? Anybody have any suggestions or thoughts or had a patient that looked like this? All right. Maybe somebody said something, but I didn't hear anything. Maybe my speaker's not working, or maybe the speaker's not working. So really, this is a hyper-CVAD regimen. So what happens is you hold the doxorubicin and vincristine because they both require hepatic adjustments. This was likely, the hepatic insufficiency was likely being treated by the disease, at least that's the thought. You give respirocase, milligrams. We would probably do 3 milligrams now and check the next day and redose. Start allopurinol. And if we look, the uric acid goes down nicely, which, for some reason the chat popped up, but I don't have the screen there. So if it's easier just to mention, speak out.
Hey, Mike, it's Matt. I was just saying the common translocation for anthracycline can show up. Anthracycline-related AML can show up on the hem-onc boards, and it's the 11q23.
Right. So that's different than the one that you commonly get with Etoposide, which I guess I don't know that offhand. But thank you.
Yeah, and the timeline's a little different. Etoposide's later.
Okay. Yeah, I know they do have different timelines. It's like originally they were treated differently, and they probably, they have different causes, different mutations, but I think now they're all grouped in therapy-related AML, probably because they have similar disease, similar outcomes, and they're both high risk, is why I think they lump them both into that, therapy AML category. All right, thank you. So, labs after chemotherapy, if you look, the bilirubin went down nicely, and the patient did end up receiving the doxorubicin and vincristine on day 3. So quickly go to Doxil, different indications, AIDS-related Kaposi sarcoma, ovarian cancer, which is probably the biggest use we see that in. It's a liposomal product. I'm going to skip through some of this because we're running out of time. The side effects, palmar-plantar erythrodysesthesia, so this is dose adjustment may be necessary, and stomatitis is the dose-limiting toxicity. Also causes cardiac toxicity. It's less categorized as to the amount and ratio than the other anthracyclines, and I do remember one Gyn patient who was well around 1,000 milligrams per meter squared and still getting treated. I'm assuming because the disease was still responding. So you can definitely tolerate accelerate more cardiovascular-wise. And this one quickly is kind of interesting. I'm just going to go over it quickly. This is a liposomal product of daunorubicin and cytarabine. So the drug developers took two drugs that are old drugs used to treat AML, and they found from basically, I'm sure, like benchtop research, that this fixed molar ratio of 1 to 5 is the best ratio for killing these tumor cells. So they developed these liposomes that had this combination that reduced those drugs or released those drugs in that particular effect. So 99% of the drug remains encapsulated in the plasma and is delivered to the leukemic cells in the bone marrow. So it persists in the bone marrow, and it undergoes this degradation, and then these are released at the right ratio that you get the maximum killing. So I believe originally this was thought that, yes, this is great. We're going to be able to do this. It works in resistant disease, which is or higher risk disease, which is why we have the indications for therapy AML and AML with MDS-related changes. But at least from my experience, and I don't know if anybody here has one, that it seems like that this definitely has more side effects and definitely is more maybe marrow toxic, probably because, you know, it enters and persists in the bone marrow. All right. So unless anybody has any thoughts, comments on that, we'll just move on to the next one. So this is a 49-year-old with IC3 poorly differentiated adenocarcinoma, ovarian cancer. So she's receiving paclitaxel, and she undergoes flushing, red face, heart pounding, seeing spots. So she gets dexamethasone and diphenhydramine. It's restarted. She has dull pain in the abdomen, cold clammy hands. They restarted again. So she got her Taxol. She's allergic to that. They didn't give carboplatin. So they decided to drop the Taxol and do carboplatin and doxorubicin, which in this case is a liposomal product. So she only gets 7 cc's of the doxorubicin. She gets feels hot, flush, chest heaviness. So again, she gets steroids and diphenhydramine, restarts. She ramps up to full speed. Halfway through her then she gets carboplatin, and she notices this rash on her trunk. Well, is this the doxorubicin or is this the carboplatin? So they decided to continue with carboplatin and doxorubicin. She comes in the next cycle for her clinic. These are the orders, so they're just single orders. They look very much like you would see. In fact, I just copied these out of a treatment plan. And the patient actually said, I don't remember exactly the details, but she said, no, you have to do it this way. And she actually had a copy of this in her hand or with her. And she knew because she had an allergist who had talked to her and provided this information. And this is the desensitization for the doxorubicin. So just quickly looking at this, I don't believe carboplatin has more of a standard desensitization, which she also received. Doxorubicin, a protocol you can use. But the doxorubicin, this was, as far as I know, patient-specific. She had this with her. If you look, there's 3 different concentrations that are needed. There's 12 steps for this, which makes it really hard to do in clinic. So she was sent home that day, and she was basically admitted into, as an inpatient, to receive both doxorubicin and carboplatin desensitization with these steps. And then the orders actually look different, and basically we had 3 different bags, 3 different concentrations that had to be used, and they were all ramped up at 4 different points in time. So these are all blue at the top, so we're going to skip all these. Quickly going to talk about mitoxantrone, used for AML, but it's all usually as salvage, so it's part of the like CLAG regimen. I guess the M is mitoxantrone. It can also be used in prostate cancer. It is bright blue if we look at the bag here. So it can color your urine blue or green. And I'm not going to go through this, but I will mention that in the 20 years I've been here, that I've seen 3 patients that have this bradycardia, even people who were high. This patient was in their hundreds, and then they brady down to the low 40s, somewhere around day 3 and 4. And the 3 we've had, we continue to treat them after their 5 days of mitoxantrone. Around day 6 and 7, they recover to their normal heart rate. And I haven't really seen this in the literature, but I have seen examples here. Not going to talk about the drug interactions except to say that azoles, there's an interaction, increased QT prolongation. So when you're using anthracyclines as an induction regimen for AML, that you're generally going to hold these for the first 3 days, and probably you should do it a couple days before because, for example, posaconazole has a 20-hour half-life. So you should probably stop at 2 days or so before. If they actually, for some reason, need treatment or coverage during that time, we can just use, echinocandin. We can use micafungin. And generally, we'll start the azole prophylaxis on day 4. Skip these. We'll quickly go to etoposide. Again, this was found by screening. These are not intelligent designed products. This had been used a long time by native people. It is the 2nd-generation semi-synthetic drug. It's non-intercalating, so it's a pure topoisomerase 2 inhibitor. You see this for refractory testicular cancer, small cell lung cancer, and as part of BMP conditioning regimens. What's unique about this drug, it's one of the few drugs that, cytotoxic drugs that is oral, so it's about 50% absorption. So you can, in some of the regimens, do day 1 intravenously and send them home on days 2 and 3 with the oral regimen. And basically, you just give twice the dose. So you'll give the same dose, you'll just give it twice a day. Hypotension, if the drug is given too rapidly, this generally happens at high doses where you're getting 50 and 60 milligrams per kilogram. It's much less common at doses of like 50 milligrams per meter squared, 100 milligrams per meter squared. And just to mention, myelosuppression is dose-limiting toxicity with conventional doses, reversible non-cumulative. With high doses, it's really mucositis and stomatitis. So 50% of people who get the high dose, which is transplant conditioning regimens, are going to get this mucositis. Much less common, like I said, with standard doses. We have seen it, and for some with tablets or capsules orally, and the thought was for some reason they're having maybe slow absorption, and it was working more as a continuous infusion and you're at higher risk or, risk factors like patient is smoking or something. Again, secondary malignancies with AML. Headache, fever, bronchospasm, all can happen. Neurotoxicity is rarely reported. And we won't go through the adjustments here. There's a hepatic adjustment. It's a weak adjustment, and it's kind of based on lower albumin and higher free concentrations of etoposide. So taxanes, a long history discovered in 1963 from the Pacific yew tree. There was a lot of controversy at the time, but they didn't know how effective it really was going to be. But even for clinical trials, you had to cut these old growth trees down to get it because the precursor product was in the bark. Eventually, they were able to get it from the leaves, and also like docetaxel, they could get a precursor from the needles of a different tree, the European yew tree, and then a semi-synthetic form. And if you just look at the molecule here, I don't remember a lot about my med chem, but it is a complicated molecule to synthesize, which is why they really needed the precursors. So it took them a while to figure that out. And the difference between paclitaxel and docetaxel is really semi-synthetic. And, well, here, let's go back a little bit. So taxanes promote the assembly of microtubules from tubulin dimers, so they form this stable structure, so you can't go to mitosis. And these tubules remain stable even in situations when they shouldn't, when they should disassociate. So stability basically leads to the stopping of mitosis and then apoptosis. So this is just a schematic at the bottom. We won't detail here, you can look at it later. Resistance is multi-drug transporters, which is similar to other drugs. And it's the MDR, not the MRP, if that matters. So it really is only one of the pumps that really works for this. The other resistance you can get from structural alterations of the alpha and beta tubulins. Not going to go through the indications, not going to go through the doses, except to say there's a wide range of doses. Infusion times, paclitaxel, generally it's 1 or 3 hours, but I can remember when the drug first came out for ovarian cancer, they were 24-hour infusions. So patients would be admitted on F66. It was known as Taxol Tuesday. They would get 24 hours of paclitaxel. They would get cisplatin after that, and then they would go home. But they found out shorter infusions were just as effective. And they actually studied 96-hour infusions, so it has a wide range of activities. Paclitaxel, probably keep this in mind, is that it has a disproportionate increase in dose escalations, and not 100% sure why this is. It's thought to be due to some of the dissociation of the solvent that it's in, which is Cremophor EL. It's not a very soluble drug. Docetaxel has linear kinetics throughout the treatment range. And really what this means is if you increase the dose, you can get increased toxicity, but you also have to be careful. If you decrease the dose 25%, you may be having a more significant decrease in exposure area under the curve than 25%. Hypersensitivity reactions, it's on everybody's mind with Taxol. They have different symptoms, mild, moderate, and severe, and that determines the treatment, what you're going to do. But basically, it's going to be a steroid and an antihistamine and famotidine or an H2 antagonist, along with albuterol if they need that, or they can use epinephrine. Generally, if you have a severe reaction, you're not going to re-challenge. There are case reports where if you don't tolerate paclitaxel, that you can have Taxotere or docetaxel. They have different solvents, and docetaxel is polysorbate 80, which is less likely to cause these infusion reactions. And of course, the taxane itself can cause these reactions. Pre-medications for preventing hypersensitivity, these were developed from a radiocontrast protocol. I think it was Cleveland Clinic. And basically now, because people are treated, like, for example, breast cancer, get multiple cycles, that you want to decrease the steroid exposure. So you want a steroid exposing effect. And I saw ovarian cancer the same way, that you decrease the amount of dexamethasone with each cycle. And I'm not sure if anybody has an experience, they get to the point where they don't need any steroids. I suspect they help with the delayed nausea and vomiting, but bone marrow suppression, neutropenia is the dose-limiting toxicity. Alopecia is going to be in all patients with doses greater than 130 to 150 milligrams per meter squared. And cardiac toxicity, I just want to mention, it's usually asymptomatic. Hypertension or bradycardia is the most common cardiac effect. Peripheral neuropathy, 27 to 60%, which is a wide range. This increases with subsequent doses. It's numbness and paresthesis and it's glove and stocking distribution. So normally the nerve body is spared, so it's the axon with the tubules that get affected. So usually that this is going to be reversible. It may take months after it reverses, but usually it's reversible once you stop the drug. It's similar to the Vinca Alkaloids, but less toxic. And more pronounced in short infusion and weekly schedules. And of course, it's increased when you use it with other drugs that are neurotoxic. We'll skip this one. And myalgias and nephralgias. So this is common, 1 to 3 days, people get these flu-like symptoms. It's usually self-limiting, weak association with cumulative doses, and, you can treat it with nonsteroidals or opioids, prednisone, but I don't think there's anything that works great. There's no magical cure that's going to stop or prevent this, and it's not dependent on infusion time. I do want to mention this black box warning for docetaxel, increased mortality with abnormal liver functions. So if you have this increased bilirubin and AST, ALT, or transaminases, that you're going to not want to give the drug because you do increase the risk of patients' mortality. This, at the very bottom, it shows severe fluid retention despite dexamethasone. This is unique to docetaxel and doesn't happen to paclitaxel. This is a poorly tolerated peripheral edema or generalized edema. It really happens around, it's cumulative, so you get 400 milligrams per meter squared. This is one of the reasons that you pre-med and you have a different pre-medication schedule with Taxotere than you do with paclitaxel. It also helps with the hypersensitivity reactions, but really it's supposed to help this peripheral edema, which can actually take, I don't remember the number, I think it's like 16 weeks for some people in severe cases to resolve. You get nail disorders, hyperpigmentation, and your neurological effects are less with paclitaxel, and neutropenia is maybe deeper, but it tends to be shorter lived than it is with paclitaxel. And I'm not going to go through all of these or the drug interactions. Quickly want to go through the last class of drugs that we have is the Vinca Alkaloids. So these are naturally occurring semi-synthetics. These are some of the oldest drugs that we have. If we look all the way back to 1963, they come from the periwinkle plant, I believe from Madagascar. Originally, they were isolated. And this is just the structure. We're not going to look at that one. But these are cell cycle specific. They bind to sites, tubulin sites, which is different than a taxane. So they have this Vinca domain. And they induce conformational changes, increasing affinity to expel. So it basically forms these paracrystalline aggregates that you can't use for this to form these microtubules, and basically causes them to shrink. And this is just a quick schematic. And if we look at the microtubule and we look at these little dimers, and the Vinca alkaloids they bind these dimers, those little Lego pieces that build the microtubules, and cause them to stick to each other. And when they stick to each other and form this crystalline aggregate, they aren't available to form these microtubules. So again, they affect the tubules, but in a different way than the taxanes do. They do share some cross-resistance. I do want to mention this is fatal if given intrathecally. I'm not sure why it took the world so long to do this, to prepare these in bags now so that you won't ever give them intrathecally. And you may think this never could happen, or how could this happen? We actually had a case here where a patient was getting the same day, they were getting some IT chemo, they were getting vincristine, and they got only 1/10 of the dose. It was like a 2 milligram dose that was given intrathecally before it was noted. And the patient didn't die, but they couldn't walk when they ended up leaving the hospital, and that's 1/10 of the dose. Most people, if you do receive the full dose, that you are going to die. They do have treatment algorithms, and I kind of listed them here, but I don't think they really have great success. So this is a case where the system was really changed to prevent any types of errors like this. These are vesicants. The unique thing about the Vinca alkaloids is almost everything else gets ice packs, whereas the Vinca alkaloids actually get warm compresses to help, and you can use hyaluronidase, which helps disperse the drug and minimize the discomfort. Just to note, if either of these, the Vincas or the Anthracyclines, if you have any extravasation, you're going to want to likely get a plastics consult to evaluate the damage and any treatment that you might need. So toxicological profiles differ between the drugs, and we'll just focus on vincristine, which is the prototype drug for this class. So neurotoxicity is dose limiting, appears after 5 to 8 milligrams, can be profound after 15 to 20. And this, I just wanted to quickly go over because I think this is interesting. If we look, this is Paul Carbone, whom our cancer center was named after. This is 1963, so this is the same year that the drug was approved. And let me see what I have to say about that. So these are 40 patients who had a malignancy was beyond the control of surgery. So these were Hodgkin's patients. They were treated to the point of toxicity, and the paper says the paracentesis was reversible within several weeks, but could persist up to 6 months. And the conclusions were that the toxicity of vincristine is dose-related, which this graph shows very well, and the tolerated dose is 0.05 milligrams per kilogram, which is the arrow on the right, where we look at the toxicity levels. I think that is interesting because on an average, say, 80 kilogram patient, that's 4 milligrams per week. So this is a weekly dose. That's probably twice what we would give now, and patients would tolerate. But looking back and reading the article in 1963, there really wasn't a lot of meds to treat this. And it did say 10 of the patients were Hodgkin's patients, and all 10 of them had tumor regression with this. So there really wasn't a lot of other options at the time. So, and this,
they were also probably younger.
Yeah, that makes sense a lot. So just the risk factors, dosed, we saw that pre-existing neurological condition, diabetic, alcoholic, neuropathies. For nutrition, there's an interaction with L-asparagine, which so you can see both of these drugs sometimes used in ALL regimens. And really the maximum dose, we generally cap it at 2 milligrams and try to minimize it. It seems like this is the first drug that is dropped in a regimen. Sometimes people decrease the dose from 2 to 1. Sometimes physician preference, they will just drop that. All right, with that being said, I just want to quickly go to, unless anybody has the answer, which I think we went over last year, is the reason we use meter squared is, I think, kind of interesting is, let me just go here. This left line, so, oops. Oh, can we see the screen here? So this is, again, this is from 1958, and basically a quick summary of this is they were looking at toxicity for these different chemotherapy doses, and they used this model where you went like mouse, hamster, rat, things like that, and you treated them to this toxicity, and when they look back at it, the thing that correlated most to that, and it's the right column, is the total dose per milligram per meter squared. So that's kind of where the idea was that, oh, we can extrapolate that and use that for treatment, and we will dose things on meter squared. I suspect, personally, nowadays, if we were doing that for these cytotoxic drugs, that maybe something like lean body mass or something that is a little bit more reflective of the elimination